everybody. It's lovely to be able to join you for this evening's session. Thank you for the opportunity. I'm based at the School of Population Health at the University of New South Wales. So I'm an infectious disease social scientist. And I focus across a range of different areas, really focused on enhancing engagement and communication. And that my work can be around immunization. It focuses on pandemic preparedness. It also focuses on enhancing engagement around infection prevention control and antimicrobial stewardship practices. But I will be focusing on the immunization elements today, throwing us back into the chaos that was the COVID-19 pandemic. Because I am presenting to you from Sydney, as is the tradition here, I pay my respects to the traditional custodians of the land. And so I'm in the kind of Sydney coastline. So it's the Bedegal people who are the original owners of the land. So pay my respects to elders past and present. Obviously we come with a mix of backgrounds, and I'm not familiar kind of whether people work across health related fields or what type of fields, health related fields you work in. So I thought I would throw this slide in just to kind of get us all onto the same page. This is the factors that have been known to motivate people to go and get a vaccine. And this might be obviously the COVID vaccine, but it might be about other vaccines that we promote for children, adolescent, and adults. And they are really kind of lots of the thinking, feeling elements, how people perceive the safety and effectiveness of the vaccine, their personal risk, whether they think it's a necessary vaccine, whether they trust the process of the development and the kind of people recommending the vaccine. These factors all change, and some people may put more emphasis on concerns around safety as opposed to factors around trust. But we know that these elements also change over time. And so we saw that all play out during the COVID pandemic. And what obviously is critical about this is that we have ongoing, clear, transparent communication about these elements, and communication that comes not just from government, but from a range of different actors, and whether that be healthcare workers. We know that people put a lot of trust on and are influenced by the recommendation from a healthcare worker. So it can sway people if they were uncertain about getting vaccinated. It can help them, push them across the line to go and get it. So we need people to be effective communicators across a range of different sectors. And this aligns to this nice framework that the World Health Organization put out during the pandemic, which I helped with the kind of development of, and put a range of tools together to help actually measure some of these elements, but really kind of highlighting that in order to get people to the behavior, we need to be conscious of the upstream elements and make sure that we are supporting people on that journey. And we know that during COVID, people's information needs changed. There was a huge amount of information at any one time to try and navigate through. And we were really asking people, especially in my area in immunization, to take on a lot of information that previously they haven't necessarily engaged with or wanted to kind of navigate through. But suddenly everybody wanted to know more and more about the vaccines in a way that, we haven't necessarily previously had to kind of deal with. Lots of people, say for the flu vaccine, every winter, roll up their sleeve, they go and get it or they don't get it. They don't really ask the kind of questions about, what technology has developed this vaccine? Is it this mRNA technology? How did that mRNA technology come about? Is it going to change my DNA? We were getting so much more, different conversations from people than we'd ever experienced. And obviously in Australia, we have community members from a range of different cultural and linguistic backgrounds. I think we speak over 300 different languages, and that doesn't even include the Indigenous languages, which I'm not focused so much on this project. We have we have about 50, it's now 51% of our population who is a migrant into the country, and roughly about 15% who speak another language other than English as their primary language. And a large proportion of those that have very minimal English skills. And so, again, in this COVID space, we were very heavily reliant on information coming in English. It was very dense information and it was rapidly changing. And so there was a lot of concerns being put out that obviously we weren't bringing the community along with us in this journey and helping them to actually talk COVID, to actually be able to navigate all of the different terms, the jargon, and the scientific terminology to be able to make their own informed decisions. And this was even pre-vaccine being available, just their own decisions around kind of the other public health strategies that we were asking them to take. And so, lots of discussion and lots of conversation around health literacy, and obviously making sure that information was being presented at the correct readability levels and taking into account the variations in health literacy in the community. And this work by colleagues at Sydney University showed that we weren't doing that. And no surprise there, all of our health information fails when it comes to health literacy and readability scores. We didn't do it pre-COVID. We definitely weren't doing it during COVID. And so, as I said, we had lots of information being pushed out to communities about these vaccines and starting to ask people to really engage so that they could make the decisions around whether or not they would want to receive the vaccine. And so, talking about, the mRNA, about efficacy, about the ways that, the different strains work, it was so much, tech terms coming through in a very short way without really any supporting, materials there to help people's comprehension. And even terms that we take somewhat for granted just were not resonating across different communities. And this is my favorite one. It's a term that we use just flippantly in immunization world, rolling out a vaccine campaign. But rollout actually means very little to people. It doesn't translate well. It doesn't necessarily have that same meaning when you try and use it across languages and across cultural groups. So this put us on the path of actually trying then to come up with a tool, knowing that the vaccine program was full steam ahead. We were aiming for 95% coverage in the target groups. How were we going to get there? Well, we needed some tools to help support people. So I came up with the idea of producing a glossary of medical terms that had some sort of, that were around the concept of immunization, but broader than that, were also around the kind of COVID-19 vaccine development space because of that kind of increasing concern we were seeing around this kind of new technology being used. And so this process started, and I think at that point I realized I'd bitten off more than I could chew, um, and didn't quite appreciate kind of just how many terms there were going to be out there. So we looked through all of the different kind of um, technical handbooks that were being produced by the pharmaceutical companies, by our Therapeutic Goods of Australia, by our immunisation committees and our advisory groups. Really scaling and finding all that technical terminology, but then realizing that it wasn't just that technical jargon that needed to be included, but words like rollout, just that kind of normal process elements that we needed to also include. So we finally got there. We hopefully found all of the terms. And as a starting point, then we tried to simplify them. So we used all of the tools that were available to um, look at, making sure that the terminology still was scientifically correct, but it also then met the recommendations around health literacy and readability. And so that took quite a lot of backwards and forwards. And I was very grateful to have a team of immunologists and vaccine experts who kindly jumped on board to make sure that in this process of refining these definitions, that we weren't losing the scientific meaning behind them. And so I had a full set of reviewers that, as I said, mapped across the kind of immunization space. So really, people, and Chris Blythe, if may not know, but he was heading up our Australian Technical Advisory Group at the time on immunisation. So had a very senior role and very kindly still jumped in and helped me on this. I had experts who worked in health literacy, and this group kindly also lent me this tool that's now publicly available. At the time, it wasn't, to actually test the glossary to look for the appropriateness of the refined terms. I had people who worked in multicultural health whose whole role was to engage with people from community and ensure that the language was resonating with them. And then I also had a team of people who actually are certified translators. And this was not covering every language. We knew we couldn't do that. But people who just day to day are used to looking at government documents, technical documents, and actually refining them. And so it went backwards and forwards, and I received lots of emails with lots and lots of comments on the side of them, having to just go back to the drawing board and try again. And this was, to note, pre-AI. So there was no ChatGPT at that time. I almost wish there had been, because that might have made it slightly easier, but there wasn't. So we just kept back at it. And then the health literacy shell. So it's an online tool that actually not just gives you a score, but actually shows you the elements in your writing where there is the potential for refinement and where you could actually switch in and out words to help with the reducing the complexity of what was being said. So that is a publicly available tool now. So I do encourage you to check that out if this is part of your work. And so yeah, we kept going. We got there. Finally, I even found one for rollout. I was able to to come up with something for that. And we were very lucky to actually then get funding to translate it. Now, this is where I acknowledge that we didn't go about this process in the best way. And from all of my learnings and all of my collaborations now with people who are certified translators and who work in translating interpreting services or support that sector, starting with an English document is the absolute worst thing we could do. What we really should have done, and this is hindsight is a wonderful thing, was for each of these languages write the term firstly straight into that language and not mess around with the English elements. That is where best practice is. That is where the gold standard is. And that is so far removed from anything we have in health, and especially during pandemics, to actually be able to do that. A big shout out to Lisa Woodland, who's part of the New South Wales Multicultural Health Communications Units. With her support, we did get to all of these languages, and they were translated firstly, checked by a second person, and then had another third check to them. So that was 3 checks for each language. So you can, the volume of work to try and get this together was huge. And this is only for one particular element around all of the kind of health promotion activities we were doing through COVID. This was only really around immunization. And so, acknowledge that we could have done this around a range of things. And it's that standardization of language that, to me, has been a huge lesson learned in this, that, in all of the government documents and all of the kind of health promotion materials that were going out, it was so easy to find issues in them because, we were producing them firstly in English and then translating them. But secondly, we had not done the basic kind of homework in the beginning of the pandemic to say, right, when it comes to the word isolation, how are we going to define this word and translate this word and keep that consistent in all of the materials going out, so that we don't have any gray area around, how that word is being, used in different way, in different by different actors. So, that was definitely one of the key lessons, and I don't think we've still got that right. I'm not seeing, any kind of movement around that. We know within an Australian community, and certainly relevant to lots of other communities out there, that when it comes to groups within a country, we often target what we define as high volume communities, groups. And that might be because there are just more people in that setting who speak that particular language. But there may not be the group that you actually need to support, because that high language group may actually be the group that's been around in the country for a long, long time. And they have huge amounts of built-in infrastructure within their community, as opposed to a group that's only maybe new and emerging within a setting. We started to develop some reviewing instructions to help with this in the future. Again, they need to be worked on. So lots of challenges, and I'm conscious of my time. Timeliness is a massive thing. Funding, there was no precedence for this. There was, I was knocking on doors to say, would you fund this? Is this something within your remit? And people just not quite appreciating where we were trying to get this to, and who the target audience was. And I should have mentioned that to you earlier. Sorry, but this, when we started this this glossary, I don't even think I appreciated who the end user could have been. And in the end, we were having, interpreters and translators coming up and saying that they were using it. We thought it was directed at government and the people who were developing the resources. But actually, in the end, it was those who were bedded into the community, who were doing that day-to-day digestion of complex material to community, that we're using this resource. And so that's where we need to, we can't underestimate kind of the people who are on the ground, who are doing all of the breaking down of material and trying to make it relatable to community, that we need to put these resources to. We developed it as it was an online PDF. but now we're moving and we should have an app-based version available, and it will be broader than obviously COVID, and it's encapsulating more just generic immunization terms. And correct grammar and accuracy. Oh God, I could go on for that for a long time. But very proud to say that the glossary got out of Australia and ended up in Nepal. And so it was picked up and actually the whole process was done again locally, and they used it also to try and help with the rollout in country there too. So look, it was a huge team effort, and I acknowledge my collaborators based in Sydney. We've never published on it, but it has been picked up in some specific, there are some articles out there that mention the development. We focused our efforts beyond the glossary. We were doing a big program of work around communication efforts from community leaders and community organizations, and kind of how were they being supported and what the gaps were for them. And so that kind of took us a little bit on a sidetrack. So we probably should go back and publish it, but it's yeah, so it was a great piece of work. It's still ongoing. I think there's scope that these kind of glossaries are kind of being recognized. For those who work outside of health, in Australia, there is a glossary to support translators and interpreters working in law courts. And so to help the breakdown of law-specific terminology, there is an online app-based glossary for that. So that kind of inspired us somewhat about where we wanted to go with this. So look, before I finish and I'm done, I just want to just do a little bit of a plug. We are at the moment seeking a collaborator based in Japan, very timely, to do some new work around the capacity of healthcare workers to communicate and advocate for adult vaccination. So we don't necessarily need someone who's just working in immunization, but maybe anyone who's got any kind of public health interest, obviously the communication element. And it will be a multi kind of phase study where we're surveys and some exploratory work, and then we're actually going to develop a tool and test it in country. So if there's anyone interested, please reach out. It would be lovely to connect.